So my first name is Deepak, and I run a European not-for-profit institute that I founded several years ago, which is called the European Institute for Innovation Through Health Data. And it focuses on being a catalytic organization to enable all stakeholders in the health space to maximize the value we collectively get from health data.
I'm a director of consulting services in a Greek innovative company called Gnomon Informatics, working in the interoperability domain in Europe since 2008 and building products in a co-creation mechanism. So it's exactly what we are discussing here. We are not trying to impose on the users how they should work, but totally the opposite. Give them the tools to create whatever they really need. And we have created all this strategy based on the use and of international standards like HL7 and IHE. In our domain, at least this is the most common ones. And this seems to work pretty perfectly. And we're trying to introduce this approach in Shapes, as you said, participating in the pilots there, but also trying to create a standardization view of things. So give an output from Shapes about standardizations, both on the health data management, but also a bit wider, as we're discussing here today.
Faith Lagrange, I'm the director of our government business in the UK for Microsoft. And that covers kind of central government, but also local government and kind of housing associations. The particular interest that my team have and have had for a long time is a real focus around supporting local authorities with kind of the use of technology and the transformation of the delivery of social care. So we know that, you can't avoid the fact that it's massively underfunded today. That funding problem is not going to go away. Demand far outstrips sort of supply in this area, and with the demographic pressures we're going to continue to have, that's something that absolutely has to be addressed if we are going to continue to live longer, but currently it looks like less healthy lives, which would be kind of a tragedy. So we work very closely with a number of local authorities, and again, really thinking about kind of the use of data, the use of IoT, and again, how the kind of housing element kind of plays a role in that and enabling people to have kind of a fit for purpose abode as they age, as they become older citizens, that really allows them to then, take advantage of what technology can bring and allow local authorities to provide much more kind of preventative and personalized care. That probably is maybe a holy grail. We'll come to that question, but that's really where our interest is lying, and then how that interacts then with kind of the health service.
Can you hear me? I met Ian working in corporate finance and deciding that I wanted to do something that would make a difference. The long-term care revolution was an introduction to that. And off the back of that, I founded a care technology business. And after exiting that, so that's still running, but as part of a bigger organization, I then set up a business called Dovetail, which looked to address the interoperability problem, really looking there at how you could give patients greater control over their medical data so that our own health information is more patient-centric, and that organizations can access data about you as and when they need to, rather than you simply being a data subject and the organizations being the data controller. So I'm actually now part that company was acquired by EMIS Group, which is one of the big electronic health record systems, EPR providers in the UK. Okay, so I just wanted to start with kind of, why interoperability is super important to us. And when I say us, I mean EMIS Group, but it's been a kind of key part of my business mission for a while, I suppose. So, I mean, at EMIS, it's kind of bread and butter. Interoperability is what we sort of focus on every day, because hundreds of thousands of clinicians rely on us to deliver the best care to patients fundamentally. And those clinicians need the right information at the right time in the right place to make the right decisions. Also, I have the data and analytics team at EMIS, the product team that work for me. It's also really important sort of retrospectively. Yes, it's important for direct care, but it's also essential that all the data from the disparate systems and different parts of the care system are pieced together, because, those actionable insights that you can get from piecing that data together really drive innovation and service improvement. The next slide, please. So I think it's just important, looking at where we are now, it's really important to remember from an interoperability perspective that many care providers don't even have digital systems or internet connectivity, so let alone having sort of interoperable digital systems. So if you don't have an electronic patient record or you don't have an internet connection, it's kind of hard to think about interoperability. Also, just how complex the landscape is. There's about 70 major IT suppliers and hundreds of smaller ones across the health and care system. So it's this incredibly complex landscape to agree standardization across. Having said that, because it's easy to focus on the negative, I think we are making sort of huge steps, not just across the UK, but globally. We're embracing coding standards, SNOMED CD, ICD-10, etc. We're using FHIR messaging a lot more. There's APIs available across the healthcare ecosystem, and also patients are getting more and more access to their own records. So we're definitely taking steps in the right direction. Next slide, please. I just wanted really quickly to touch on this. This is the priority areas that the CCIO for Health and Care in England listed. So this is kind of our starting point. I guess maybe it's fairly fundamental to know who the patient is. So you need a unique identifier. You need to know who's delivering the care. You need to know when that was done. And then there's kind of the basics in terms of observations, diagnoses, treatments. It's very much focused towards health and not social care, I would say, at the moment. But, you have to start somewhere. So this is kind of step one on that journey. Next slide, please. Sorry, excuse the terrible pun on this slide, but it popped into my head and stuck. So I really think it is the holy grail. I 100% agree that interoperability is where we want to get to. It's pretty obvious why. It's not just that data saves lives, but data saves time, and that with this sort of massive Great Resignation workforce problem looming across healthcare globally. We're talking about hundreds of thousands of healthcare workers that we're going to be short to deliver the amount of care. I think time saving is really important. And also it saves money. And with a world of potentially incoming austerity, it's absolutely what we need to strive for. So I suppose in conclusion, it's not a pipe dream. It is definitely a holy grail, and it is going to be a long journey on a winding road with many potholes, I would say. So yes, that's all I wanted to say. Hopefully 5 minutes, bang on.
Look, I think it's really interesting to hear Alex speak. Absolutely, I agree with everything that's kind of been put up there. I think from our perspective, it absolutely starts with the data in terms of interoperability. You can have lots of different systems, and the problem is the data is then siloed in those different systems, and it's not kind of shared. There is absolutely the question of patient control over that data, and that is something that needs to be considered. How the data owned by the person and being able to decide what that is used for. But there's absolutely a case to be answered for institutional sharing of data to allow patient flows and then flows between health and care. I think the interesting thing for us, I guess, just building on some of what Alex has said, is all of those advantages of interoperability and data sharing absolutely stand for the health service, but it should start much, much earlier. There are people taking up time and resources in the health service that should never have had to get to that point. They shouldn't be in an acute care setting. They should have had the support and been enabled to stay at home and be and kind of been given that opportunity. And that's the really important piece around that connectivity between social care and healthcare. There is this great resignation coming in healthcare, but in social care, they are just struggling to get enough care workers to be able to service the needs of the population today, let alone any increasing need, let alone anything that's going to start to come and hit as a result of increasing austerity and the cost of living crisis that we are in and is going to get worse. So actually being able to think about then how you use data and interoperability to be able to provide those personalized and preventative services so that, yeah, it saves money, but actually improves citizen outcomes before they become a patient, before they start taking the resources of an already stretched healthcare system. That really is where we should be trying to get to. Where can you understand where the point of need is greatest and intervene early so that you don't end up using expensive resources that could be targeted elsewhere for the people who genuinely require it, rather than just there is nowhere else to go, there is no other resources to use at this point. And I think what's really important, and where I think it really links into some of the conversations that we've been having with Ian and the team, is kind of the housing and standardization of that, the opportunity for multi-generational neighborhoods, really feeding into that, because we can get a bit too narrow in how we think about data. So longitudinal health and care records are kind of only part of the story, really. We need to think about place-based data. We need to think about the ecosystems which bring together a much wider base of information. So housing, social care, neighbourhood information and statutory data. We've got no contextualisation for the information that we have if all we are looking at is the patient care record of the individual. So we don't understand what the wider determinants are of health if we don't have that visibility. What part does education, kind of housing, poverty play in and around that allows us, again, to think about how we can put in preventative services and targeted services for individuals. And I think that as we move towards kind of a kind of broad and inclusive place-based ecosystem of data centered around the individual and their requirements, that really is the holy grail, I think. And it is possible, but it's going to require a change in thinking, a change in approach, and ultimately kind of probably a change in the way that kind of public sector budgets around those things as well.
I'm coming from a small country, which is Greece, and which is one of the countries that has the biggest older people issue. So it's a really aging population there. And they have been starting measuring the percentage of how these people are dependent on the rest of the society and their families. So that's a new index, and it's 37% today, and it's going to increase even more. So that's one important thing that we need to take into account. Now, the other thing is there have been studies that showing that we need to find ways, and technology is probably one way of keeping the disability reduced. And this is how we have been working, at least, with very basic technologies for a long period of time, which they are working, like call centers, like panic buttons, like things like that. And we are one of the basic providers in my home country, providing support in 4 regions around Greece on that. So that's what we have today. But we really need to expand this, and the previous speaker said exactly the same thing. We need to try to find ways to give more, let's say, services to the people. On one hand, these people, they also are somehow, we live longer, but we all have something like chronic conditions that are not life-threatening, but they are with us for a long period. And we need to incorporate social care and healthcare together in one patient journey. So we need also to start thinking about how we put the patient journey in it. And as said, healthcare parameters and social parameters are not only in the healthcare system. So we need to break the bridge and try to, and this is something that WHO has already started thinking about the social determinants of health. So that's a little bit the background of all this. And where we are moving as technology, we are moving very rapidly in a world that everything is going to be connected. So the older people of today, they are living a digital divide. So that's an issue that we face now. But when we will be in that place, probably we won't have the same issue. So I really agree with the concept that we need to start thinking about the future services where we could see ourselves in that conditions in 10, 15, 30 years, let's say. So what we have created to try to do that is try to revert a little bit the idea and try to put the patient or the citizen, because we are not always ill, let's say, in the center, and try to create new business paradigms where they will be in the control over their data and try to create new services based on that. So we are creating tools like a Lego block, like a box of Lego, let's say, and in a co-creation process, we are creating new services based on what is really needed by the patients and the clinicians, of course, opening channels for them. And the data part, the interoperability part is crucial in trying to building those services because we need to bring the barriers. So the clinicians, each clinician, they have their own system, they're keeping their data, but it's very hard to get them out of there. And that's the big barrier that we're facing today. So in that sense, this approach is a bit different. So the clinician is not the center, but we have four, let's say, pillars. So the one is obviously privacy and the consent part. So we need to give the citizen, the patient, that he can handle his own data. The second is open the channels for collaborations. And we have so many technological tools here. With COVID, we saw that happening, teleconsultations, chatting, all these tools are there. We can reuse them again. The part of sales management, there are so many new data coming from the citizens and the patients themselves that could fuel the discussion and create better information, so maybe better treatment in the future based on those data. And also the interoperability. Those are the four pillars if we want to create things in that domain. And we have been experimenting with our platform in the last 5 years, trying to see and solve real-life cases. And we have now already several solutions built with this Lego box, let's say, based on interoperability and international standards. Working solutions for diabetes, for chronic pain, for hypertension, heart failure, COVID, of course, we had to deal with that in the previous years. So all this proves that this concept of building through a co-creation process is really working. Now, in order for this to work, the problem is that the data are locked where they are produced. So, and we see that at least at the European Commission level, which is 27 countries, unfortunately, UK left. That's unfortunate. They are trying, and for the first time after 15 years of discussion, they decided to put a regulation, which will mean that all countries will have to apply the same rules for interoperability, for primary use of data, so standardizing how the electronic healthcare records will be there, certify them so that all the products have the same concepts, and also put the grounds, the ethical grounds as well. So the discussion that we are having here is very relevant, so that the data that are created, structured data now, can be reused in a secondary use of data for innovation, for research, for new drugs and things like that. So this is the concept of that. And behind this is the European Electronic Health Record Exchange format. So it's a way of using standards like HL7 and IHE and other standards. I won't go into the technical details, but you can contact me at any moment, to try to create common parameters and common clinical documents at a European level. And already some of them, the patient summary and the e-prescriptions and the e-dispensation document are already common in Europe. And already 10 countries are able to exchange those documents between themselves. This is called the My Health at EU service. And new documents are being currently created about having common lab reports, common radiology reports, and common digital hospital letters or reports, which means that if you manage to structure this information, at the end of the day, you have about 80% of the record in a structured way. That's a big change in how we can see and create new services for all the population. So I think that if we try to follow this path and also have the regulation part on our side, a lot of things could change. So thank you very much.
Consensus once more. Important. Deepak.
And I am now allowed to be provocative?
I want you to, I expect you to be provocative. It was a promise.
Very good. We are still a little bit focused on trying to solve the day before yesterday problem of interoperability, which is connecting the classical sources of health data to each other. Let's say the hospital and the GP as example, but multi-hospital, multi-GP, multi-country. Professionally created data is still the preoccupation, and I'll come back to that. That's day before yesterday's problem. Yesterday's problem is adding to that connectivity the data generated by people and around people themselves with apps, with wearables. We know with chronic disease management, self-management with digital tools improves quality of life, improves outcomes, and reduces costs. I think I should carry on. That's okay, good. It's about time you got the bell. So yesterday's problem, we've got to connect the digital citizen into that data ecosystem. But today's problem is not only health data, health-related, health-impacting data, the wider data ecosystem that I've spent the whole day hearing about. That is really now today's interoperability gauntlet. It is not a holy grail because that is aspirational but never achieved. It is not a, what was the other one? A pitfall, peril, something. I forgot the word, but anyway, it's not that either, pipe dream. It is an emergency, and it is absolutely within our grasp today. The standards for day before yesterday's problem, connecting professional data, have existed for a minimum of 10 years, maybe 20 years. I've even developed some in ISO that are older than their decade. We have a problem of non-adoption. I am absolutely confident that Alex and Faith and Alexander, 3 people at the supply side end, have the capability to deliver highly interoperable solutions. The market, the demand side, is absolutely fickle. It is terrible at requiring interoperability, about being explicit, about demanding it. And that is why the average person today does not experience allergy interoperability wherever they travel around the country or Europe. They do not experience medication interoperability. It is a criminal shame that we've invested so much in health ICT in the last decade or two and not delivered these absolute basics. So please don't think that it's multi-generational to single out the elderly as being in whatever numeric value you fancy.
Banned the term elderly, by the way.
Oh, okay, good.
Well,
you did. Well, ban 65 as well, and I'll be happy. Please, that problem of today, the interoperability need for health and health impacting, health determining data is across all age groups. It is absolutely a multi-generational requirement. Please utilize your leverage as a very powerful group to lobby across all ages for that interoperability we need. We need the data at the individual level to give them connectivity, to give them the ability to leverage all of the magic you've been speaking about. But we need the data at the aggregate level so we can learn and improve and be evidence-based and influence decision-making. And if I have another 30 seconds, last point, the biggest problem with non-adoption of standards is the lack of compelling business models to make the procurements of health ICT in the past business-like when they collaborate. Organizations of the health sector do not have a business driver anywhere in Europe to collaborate. They have a business driver to deliver services themselves. Cooperation is not business-driven. If we want to see the standards I've referred to adopted inside business models of procurement, we have to make the data and we have to make cooperation across the actors itself intrinsically the business driver. Thank you.
How can you get the likes of a Microsoft to actually invest?
The customers are there, the need is there. I mean, local authorities are talking about and looking at these things. You've got integrated care systems that are being introduced in England that are trying to address exactly this kind of interoperability between health and social care. The issue is not the absence of customers or the opportunity for business to be able to provide solutions and be of benefit to business to provide the solution. That is not the problem that's out there. The problem is actually, it's one of change management, if you like. It's one of cultural change around how we think about the separation between health and social care. Alex actually mentioned it in her presentation. You've got a Department of Health and Social Care that's really talking broadly about health outcomes, but actually we need to think much more broadly around social care and the opportunity for prevention. So longer term thinking around that. But the issue is not an absence of customers or, I guess being cruder about it, a commercial opportunity for business. That's absolutely there.
I was just hearing somebody talking about this issue about the importance of the protection of individual data. And I know there's been discussion in the past couple of years about data being passed on to the private sector and the dangers about that data being passed on to the private sector, whether it's for the benefits of patients or is it for the benefits of business who are going to use that, who's going to use patient information to make more profit for the private sector.
Let me put that question to Alex.
In terms of the kind of commercial dilemma, I think that's, there is ultimately a large amount of value, but I think we need to look at value not just in pounds, but in patient benefit and efficiency, and market forces will determine that. But I think the NHS is now setting out really good guidelines around any work that is done with patient data at an aggregate and anonymised level, a large-scale level, needs to deliver a return back to the NHS, back to UK PLC, and most importantly, back to patients.
And there is a new law that was passed 2 years ago about trying to create business ethics on reusing those data for innovation, which was not there, driven somehow by the pharma industry and the clinical trials, which is a pan-European problem that was highly increased, and a lot of changes in the mindsets of the politicians try to open the data because they saw that we need to be much faster than before. So I think trying to revert to what we are trying to do, it's important to give more tools and try to change the policies to give more power to the citizens themselves. And instead of thinking about clinical data lakes, which is the common thing that we are doing now, trying to aggregate data collected in different ways and trying to make technology work on top of it, which is usually not working very well, try to create patient lakes so that the patient can collect his data in our application, in Alex's application somewhere, and they decide what they are. Probably they could even get incentives and revenue from their own data. And I know that all the patients that are in critical conditions, cancer patients, rare disease patients, they are really happy to share their data. And sometimes they have better knowledge of their conditions than their clinicians.
This gentleman has asked a really, really important question. So I'm very glad you raised it and thank you for doing it. You've actually added to the question. And I'd like to draw a distinction between two categories of information. There is information about an individual where the individual has some form of identification. like either their name or an NHS number or some other ID, and you know who the person is. And here you've heard from Alexander very clearly and very powerfully, the GDPR is a data protection regulation all over Europe, and at this moment, but without confidence about governmental policy on this, the UK has something called the UK GDPR, which echoes European rules. We might wander off in another direction in the UK, and heaven help us if we do, but at the moment we are bound by the same rules. And therefore what Alexander has said is absolutely right. The individual's data is strongly protected. And you've indicated, Faith, you've indicated, Alex, a lot of good governance practices internally to look after that. But I want to return to the second one. When the data has been really strongly anonymized to the best one can do, the individual is no longer identifiable in the data, then you're outside of the situations of consent because no one knows who's in the database. And in those situations, all of the studies done, including some done in the UK, have shown the public still care. Even if I can't be identified in my data, I want the confidence that my data are being used ethically and morally. That is what we hear from the public all over Europe. And so in addition to the protections that Alex has described, sorry, I call him Alex because I've known him for years, sorry, Alexander, I'll say now, there is separate work going on across Europe to define good practices and codes that industry and public bodies should use, even when they're handling anonymized data, so that they are behaving ethically and transparently, and the public always know how data are being used. I'm actually in the middle of drafting some text on this topic. In fact, I'll be doing it on the train when I leave this meeting a little bit. We're working on it, and your company is actually sponsoring that work. So we are doing work to try to make sure that the anonymized data are also used in ways that society cares about. Do I still have 30 seconds? The trouble with the opt-in, opt-out challenge is that the GDPR makes very clear that consent has to be informed. That means that if you are going to be asked, are you happy for your data to be used for this purpose? There are certain things you have to be told. And it takes time to communicate that. It would probably take 2 or 3 minutes minimum for a person to explain it to the patient if you're going to ask their permission, at minimum. We're seeing an increasing number of apps where you get a text message, can your data be used for this? Text yes or no. That is not sufficient for any legislative informed consent. And it's also very discriminatory because text messages, yes, no stuff doesn't span the digital divide. It doesn't span the ethnicity divide. It doesn't span the educational spectrum properly. So we have a real dilemma that if I was going to offer to be pinged every time my data might be used, I could be asked 20 times a day. If I'm supposed to be fully informed 20 times a day, no one's got the resources to inform me, and I'm not prepared to make that amount of time available on a daily basis for the rest of my life. And who's going to do it across the digital, educational, cultural divide? No one. That's what makes opt-in so challenging to deliver at scale. It sounds nice in theory. The moment you want to scale, to me, it's really hard to do it equitably, honorably, and fairly. That's my problem. I'm not saying it can't be done. I've not yet seen, and I'm looking hard anywhere where it has been done to those ethical standards of informed consent.
So to summarize, I think what I'm hearing is it's less of a technological challenge because...
Not at all. You've got 3 geniuses in this panel.
Precisely.
Not me, the other 3, who know how to do it.